My topic today is refeeding syndrome, especially early detection and management. I'm going to talk about refeeding syndrome in the current clinical practice, prevention, and early identification and management. Refeeding syndrome was described many years ago as a syndrome in a chronically malnourished individual on nutrition therapy, resulting in fluid and electrolyte imbalances. This leads to metabolic derangements, gastrointestinal and cardiac and respiratory dysfunction, leading to significant morbidity and mortality. But it was known even then it was preventable. A little nutrition is good, but too much nutrition is bad. The definition of refeeding syndrome has changed over the years, and a new definition supported by the American Society for Parenteral and Enteral Nutrition in 2020 says that a decrease of greater than 10% in serum levels of at least one electrolyte, potassium, magnesium, and/or phosphate, can be construed as being an important component of refeeding syndrome, and/or organ dysfunction due to the above, which we will discuss further, and/or manifestations of thiamine deficiency. Clinical scenarios of refeeding syndrome were noted after hunger strikes, after starvation, after being lost, anorexia nervosa, and in malignancy. In clinical practice, we very often don't see the first two, but anorexia nervosa, malignancy, and other conditions with chronic starvation, where people are fed aggressively, may result in refeeding syndrome. But why is refeeding syndrome still a problem, even though we have known about it for years? I believe it's the ready availability of products, both enteral and parenteral, easy IV access, peripherally inserted central lines, and easier enteral access. And the current incidence of refeeding syndrome is reported to be as high as 80%, even though it is difficult to define. The at-risk patients for refeeding syndrome are chronic alcoholism, cancer, high stress, elderly patients in long-term care facilities. It is hard for us to believe that obesity and after bariatric surgery are also risk factors, even though the patient appears to be fat and may not be presumably not malnourished, even though the patient may have sarcopenia. Refeeding syndrome can occur in obese patients too. As you can see on the right side of the slide, it's easy to suspect refeeding syndrome in a patient in the upper part where the patient is looking quite thin. But in the lower diagram, the lower figure, see an obese patient after a post-op complication who got fed aggressively and developed refeeding syndrome. A case report I published some years ago was on a 60-year-old obese patient with carcinoma of the esophagus, dysphagia to liquids for 1 month. A feeding jejunostomy was done prior to chemotherapy. Now, this was started at a very, very low rate of only about 4.4 kilocalories per kilogram per day of enteral feeding. And this patient developed respiratory distress, abdominal pain requiring transfer to the ICU. Severe decrease in the serum levels of potassium, magnesium, and phosphorus, all of which are intracellular electrolytes. And because of the shunting of these electrolytes into the cell, serum levels go down. This patient required several doses of IV supplements, and it took 2 or 3 days to normalize serum levels. Whereas we require only 60 milliequivalents of potassium, this patient required 440 milliequivalents of potassium and about 105 millimoles of phosphorus, even though the daily requirement is only 20 to 30. The clinical manifestations of refeeding syndrome involves practically every organ system in the body. Neurologic, sensorium changes, seizures, encephalopathy and paralysis, respiratory depression, muscle paralysis, rhabdomyolysis due to decreased phosphorus levels, causing muscle breakdown, cardiac dysfunction, abnormal electrocardiogram, and cardiomyopathy and congestive heart failure, perhaps due to thiamine and selenium deficiency. Now, even in a patient with renal dysfunction where the phosphorus levels are high, refeeding syndrome can still occur and hypophosphatemia can occur even in a patient with renal failure. Dysfunction of erythrocytes, leukocytes, and platelets are also seen. The complications of refeeding syndrome are due to the electrolyte abnormalities which I mentioned earlier. Hypophosphatemia results in respiratory failure, congestive heart failure, arrhythmias, rhabdomyolysis, altered mental status, and hemolysis. Hypokalemia, hypomagnesemia, hyperglycemia, and hyponatremia are the other features. This occurs with fluid overload, and thiamine deficiency is now noted to be an important component of refeeding syndrome, leading to Wernicke's encephalopathy, lactic acidosis, and congestive heart failure. Few words about phosphorus. Phosphorus is an important component of 2,3-DPG, diphosphoglycerate, and it is a critical regulator of oxygen dissociation from hemoglobin. So if the phosphorus level is low, 2,3-DPG in the RBC, red blood cells, also decrease. And the oxygen is bound to the hemoglobin and is unable to be dissociated from the hemoglobin. It is almost like cyanide toxicity. The blood gases may look good, but the oxygen is of no use to the tissues. Phosphorus is an important component of enzymes such as nicotinamide adenine dinucleotide. It is an integral component of structural proteins like phosphoproteins and phospholipids. Hypokalemia can manifest as cardiac dysfunction on electrocardiogram, premature ventricular contractions, ventricular tachycardia, and atrial fibrillation. And hypokalemia can also present as weakness and hyporeflexia. Gastrointestinal system changes include ileus with hypokalemia. Hypomagnesemia has major cardiac effects which may be fatal. Depolarization of cardiac cells results in tachyarrhythmias, which means fast heart rates, and atrial fibrillation. Word about thiamine. Thiamine is now recognized to be an important component of refeeding syndrome. It's a cofactor for oxidation of pyruvate, alpha keto acids, and branched-chain amino acids. But more important, pyruvate is converted to acetyl coenzyme A with the help of thiamine. And the acetyl coenzyme A goes on to the tricarboxylic acid cycle and produces adenosine triphosphate or ATP. If you don't have thiamine, ATP production is affected. And because the conversion of pyruvate to acetyl coenzyme A is dependent upon thiamine, pyruvate accumulates, and then the reaction goes backwards to produce more lactate. So when you have refractory metabolic acidosis, a person whose vital signs are fine, there is no hypoperfusion, and the lactic acid is up, and there is no sepsis, think about thiamine deficiency. We never make a diagnosis of delirium in the ICU unless thiamine deficiency has been ruled out. Can present with confabulation, confusion, Korsakoff psychosis, and Wernicke's encephalopathy, and sometimes these changes are permanent. Congestive heart failure as a feature of thiamine deficiency known as wet beriberi is well known, but abdominal pain can occur. This is called gastrointestinal beriberi, severe abdominal pain. Lactic acid is up, but there is nothing wrong in the bowel per se. Thiamine deficiency is therefore an important component of refeeding syndrome. How do you avoid refeeding syndrome? Be aware of the syndrome, recognize patients at risk, And you start correction of fluid and electrolyte and acid-base imbalances first. But there's no need to wait for full correction. You can start feeding the patient enterally, preferably, if necessary parenterally, at the same time, but at slow rates, while the fluid and electrolytes and the acid-base imbalances are also being addressed. What we need to know is calorie deficiency and protein deficiency results in higher mortality in sick patients, and therefore we should initiate enteral and parenteral feeding, maybe 10 cc's, 15 cc's an hour. But the electrolytes have to be corrected because derangements of electrolytes can result in major complications, including death. A study published recently looked at CT scans of the abdomen done for other reasons. We don't do CT scans just for nutritional assessment. And in this retrospective study of 100 patients, they found that the psoas muscle Hounsfield units of less than 25, showing that a sarcopenia, can be used to predict refeeding syndrome. In conclusion, we should realize that refeeding syndrome is still a problem after all these years. You increase caloric delivery, both enteral and parenteral, and even oral, very slowly. Administer vitamins and trace elements routinely. Monitor electrolytes, including magnesium and phosphorus. Quite often, we think only of sodium and potassium, but we must pay attention to phosphorus and magnesium. Look at acid-base status and monitor the serum glucose levels. Thank you very much.